So this talk is about the ligament injuries of the knee. So we're going to start with an epidemiology graph of the rates of ligament injuries compared soccer and basketball in men and women. And we can see the males are solid here, and then the females are hashed because they're more complicated. And the blue is soccer and the red is basketball. So we can see the collateral ligament here. Medial and lateral collateral ligaments are the most frequently injured, okay, in soccer, and of any of the other ligaments really. And then basketball a little less common, but then essentially the menisci are next, and they're about even. And then we have ACL injuries here, and then PCL is the least common. We can see, though, that the gender distinctions here are most prominent with the ACL and menisci. And then the sports differences are really marked for the collateral ligaments. They're much more common in soccer than in basketball. So what we want to focus on now is the restraints that are associated with lateral collateral or posterolateral aspect of the joint. And so basically here we have a diagram of a femur and tibia. And if we think of the biomechanics of this, basically when you apply a varus moment or an adduction moment to the knee, you're going to tense the lateral capsule, the lateral collateral ligament, and posterolateral part of the joint. So what we've done is we put the axis of rotation onto the medial side of the joint. So we apply a varus moment, the axis shifts to the medial side of the joint, and the lateral side soft tissue structures tense. Okay, and so what we want to do is think about like what kind of muscle control then would be responsible for either keeping that, protecting the lateral collateral ligament or the lateral side soft tissues when we apply a varus moment during movement. So what we're going to look at is a study that was done a few years back by Lloyd et al. In Journal of Biomechanics that did an isometric loading task and kind of calculate the different forces that the muscles could produce. And so what he came up with was when you apply a varus moment, you have like the muscles of the TFL, the biceps femoris, and the lateral gastroc, and then the patella tendon. Notice that the patella tendon pull is lateral to the axis, which because we were applying a varus moment, the axis just shifted to the medial condyle of the tibia and the medial condyle of the femur. So the moment arm of the patella tendon now is toward abduction or could generate an internal moment to oppose this external varus moment. So in combination, the patella tendon, the medial gastrocnemius muscle, the biceps femoris, the tensor fasciae lata, all could contribute to the varus moment. Now, the problem is how well do they do that? And here's the calculations here, the percent of the varus moment that they accounted for without loading the lateral collateral ligament. And the quad hamstring contraction clearly took the most of the load with about 15%, the TFL around 5%, and the lateral gastroc about 5%. And so essentially the total amount of load they were able to account for was only about 25%. So what it tells you is that in terms of medial lateral stability at the knee, the muscle control, although it is there, the physiologic cross-sectional area of the muscles in their moment arms suggests that they're not completely able to control large varus loads. So it's not something that you want to subject your knee a lot to, otherwise you're susceptible to injury. So here's an example of an injury occurring during soccer. Okay, and so there's the injury there. That's both a lateral collateral and posterolateral corner injury. So they had some hyperextension as well as a varus load. So here's the start of the injury occurrence. Let's see if we can go frame by frame here. So here's the person kind of captures the ball. Now this is going to be a semi-contact, or there's definitely contact involved, but the person doesn't like push him over. It's still this player's choices that result in the injury. Okay, so here's some contact, and we see now he's going to use his body to try to protect the ball, our guard. And now, but he ends up falling forward. And so as he's falling forward now, he's going to put his leg out to brace. See, and there he goes. And so we can see at this point he put his leg out, but his trunk was too far forward. So his ground reaction force is now coming up toward his trunk, which is causing his leg to buckle. And his muscle control is not sufficient to stop that. And so he ends up with this kind of, it's pretty ugly looking injury there. We'll kind of play it through. Okay, so we'll play it again one more time, real time, so you can see it. So these injuries usually occur fairly rapidly, so it's sometimes difficult to understand how muscle control or training could stop them, but bam, there it is. Okay, and so those are the kinds of, that's a lateral collateral ligament and posterior capsule, and the PCL might have also been involved. So in terms of rehab issues that are related to the LCL, the torn ends of the LCL don't approximate. And so, and one of the other things is in terms of normal walking, we have a propensity to gap the lateral side anyway, because of the way that the ground reaction force falls during walking. So let's study this picture here for a minute. So this is a skeleton reproduced from a motion analysis lab, and we can see the ground reaction force here in gray, and then the green are the moment arms of the external load that's being generated by the ground reaction force. So we notice that in both cases the external moment is toward adduction at both the hip and the knee during normal walking. So most of stance is dominated by an adduction moment during walking. So what we can understand by that is that if there's a tendency for the lateral side of the knee joint to gap with every step, and so essentially LCL rehab has to be careful about when you start walking, how fast, and whether there's good muscle control to protect the lateral side of the joint, or you will end up with something called a lateral thrust, where basically on every step the knee kind of buckles a little bit into adduction because of a gapping on the lateral side. So now let's shift to passive control of posterior displacement. And so this is mostly a function of the PCL, which is shown here on the posterior aspect of the joint. And one of the important things to recognize is because of the way that the bony shapes of the joint slope, so essentially at 0 degrees of full knee extension, the contact between the femoral condyles and tibial condyles prevents posterior subluxation. And so this bony contact accounts for 46% of the stability of the knee at 0 degrees. Okay, as you, the other secondary restraints are really the posterolateral structures of the knee. So this is lateral here on this knee, and so the meniscus, there's a meniscofemoral ligament here you can see, and then just the capsule that would normally cover this also help restrain posterior glide. Now when the knee is flexed, there's essentially two ways to rupture the posterior cruciate ligament. One is with excessive flexion of the knee. So if you recall, the arthrokinematics of the knee are when the knee flexes, the tibia also slides posteriorly. So one of the structures that limits that posterior glide is the posterior cruciate ligament. And so if you get something called like a dashboard injury, in this case it's showing the person falling on the ground, so the ground's like a dashboard, but Basically, if it's a motor vehicle accident, you're not wearing your seatbelt. If you're driven forward and your tibia hits the dashboard, it'll be driven posteriorly, rupturing the posterior cruciate ligament. This picture is showing something similar, only this time they're hitting the ground. So as they hit the ground, if they hit the tibia first, the tibia is drawn backwards, and the tibia, the femur continues to slide forward. That causes a posterior translation that's excessive and ruptures, ends up with an isolated rupture of the posterior cruciate ligament. Another example is hyperextension. In a hyperextension injury, where the axis of rotation shifts to the anterior bony contact as you're hyperextending. So as the anterior rotation shifts, the axis of rotation shifts anterior, then the structures posterior to that axis point stretch, and so typically that would be the posterior capsule and PCL. And so it's possible to get a isolated PCL injury that way, and then if the amplitude of the stretch is high, you'll also end up with an ACL rupture, and it's possible to rupture both your PCL and ACL while leaving the LCL and MCL intact, so leaving the collateral ligaments intact through this hyperextension mechanism. So with what's interesting about the PCL injuries is that the patella tendon angle of pull is an agonist for the PCL. So in other words, this is a force diagram of the patella tendon. So here's your quadricep force, okay? And so if we decompose that resultant vector into an anterior component, so a force of the quadriceps in the x, and then a vertical component, force of the quadriceps in the y, we can see that the quadriceps contraction actually elicits an anterior drawer, and therefore is an agonist or protective of the PCL. So the one thing that's interesting about PCL injuries is that people don't need to have, they can live with this laxity quite well because the quadricep mechanism basically controls the posterior displacement from a muscular standpoint, even when the PCL is not active. Now, one other thing that's important though is during rehab, hamstring contractions would be a negative if they some patients do end up having PCL reconstructions, and if they do have the reconstruction, using hamstrings would be limited until the surgeons or the protocol called for there to be loading of the PCL structures. And this is just a diagram showing the moments. This is the stance phase of walking, where heel strikes here at 0. 100% is the end of stance, where the toe comes off. And you can see this is actually stepping down from a step. And as you step off of a curb or a step, you can see there's quite a high knee extensor moment. And so during this large knee extensor moment, the tibia would be drawn forward. Okay, and so that's an example of how the instability that's associated with the PCL, that posterior instability, the body handles quite well. Okay, so now we're going to talk about MCL injuries, and in this particular case, we're interested in the same kinds of things. So, the passive and active control mechanisms that limit valgus. So here we see a valgus moment. Okay, and we're observing the same kind of thing that we saw with the other injuries, is that the first thing that happens is when you have an extreme load that's stretching a ligament on one side, the axis is going to have shifted to the opposite side. And so if we're gapping the inside or medial side of the joint, then the side of compression is also the point of the axis of rotation is on the lateral side. So with a valgus moment, you have the axis of the knee joint shifts laterally, which then could gap or stretch the medial side of the joint. Now, what's also been noted is that external rotation moments and motions also may rupture the PCL. So now we have the same study from before, where we looked at what closes the gap on the lateral side. when you apply a varus moment. So we're asking the same question now: is what muscles close the gap on the medial side when you apply a valgus moment? And so we can see here's the different muscle structures. We have essentially the pes anserine muscles here, which includes the hamstrings. That's why they're not listed specifically, but we have the semitendinosus, gastric gracilis, and sartorius muscles, all kind of inserting on the pes anserine, or this anterior aspect of the tibia. We have the medial gastroc muscles, and then of course the semimembranosus would also be included. And now we see the patella also acting to stabilize the knee against a valgus moment. So note that now the axis has shifted from the lateral to the medial side, and so there it has now a moment arm to stop a valgus moment or cause an adduction moment, because where the axis is now sits. Okay, so then we can so now we kind of understand which muscles are at play, but then we can combine their PCSA and moment arms to see how much they contribute to closing or protecting the MCL. So here we have the different muscles listed, and we can see the percent of the valgus moment that they take into account. And so now we have the quad hamstring contraction still is significant, but the medial gastroc muscle is more significant. Together, the sartorius and gracilis handle a little bit as well, but likely it's small because of their PCSA. But if we combine all of these now, we're in terms of medial side of the joint, we have much better muscular control. So the medial gastroc's taking into account about 25, another 10 plus, that's 35, another 5 or 10 here. We're up into the 45-50% range. So much better than the lateral side of the joint. So MCL injury mechanisms occur in many different ways, and here's some of the mechanisms that have been noted: external rotation and valgus moments placed on the knee. Here's an example of a ski caught that the tip of the ski is caught, which kind of ends up rotating the tibia into external rotation and into abduction. A blow to the lateral knee resulting in valgus, and awkward movement resulting in valgus or external rotation. So these tend to be the injury mechanisms. So the rehab issues here are interesting, where the PCL and LCL don't heal usually without surgery. The medial collateral ligament may, because it has deep and superficial fibers, and usually the superficial fibers are torn of the MCL and the deep are not. This results in some anatomic structures holding the torn ends of the ligament near each other, which allows the body to bridge the gap with new ligament tissue. But here, in terms of the gait patterns, it's exactly the opposite of the LCL. In this particular case, the gait patterns tend to just naturally close the medial side of the joint, and so it tends to you can incorporate weight bearing and walking tasks much earlier without risk of gapping the medial side of the joint and therefore overstretching the repair site. But you would still avoid full extension, as you would for all of these tasks, because at full extension all the ligaments of the knee are taut. Okay, so that's the summary of the PCL, LCL, and MCL kind of basic injury talk. Thank you.